Thank you, Antonio. Again, a special pleasure to be here. And I will start with some epidemiology consideration. DCIS is the cancer, the breast cancer that is increasing comparing to the invasive cancer that is decreasing, and you can see that is increasing proportionally to the mammography. So of course you do more mammography and you may detect more ductal carcinoma in situ. And it's very curious to see that is especially increasing in young population. Why? Because we are doing more mammographies in young women, and we detect more ductal carcinoma in situ comparing to the all groups. And in the United States, at a certain point, there was a sort of doubts on the real effectiveness of the diagnosis of ductal carcinoma in situ, especially in young women. And the media reported several times, even in the last few months, that we are diagnosing more DCIS than necessary, so we are over-treating population. And in this moment around the world of risk benefits, cost benefit, this may impact a lot the cost of the health system around the world, and even in the United States. With the proposal not to treat some ductal carcinoma in situ, and this this presentation was at the ASCO of this year, looking from the SEER data, the SEER database American data, if DCIS could have not been treated in some group of population. And there was a comparison between patients who had surgery for DCIS, patients without surgery, long-term overall survival, and stratified by grade, with a difference, of course, if the grade is high, is the grade is intermediate, or no difference, is the grade is a low grade. So is the low grade a different DCIS not evolving in invasive cancer, or is just the natural history that is most low, and sooner or later we will see the same effect as in the high and intermediate grade of the ductal carcinoma in situ? And this is, of course, an open question. Maybe not important in the 75 years old, 85 years old woman, but maybe important in the younger group of women in which the life expectancy it's really longer. On the other part, there was another interesting paper from the SEER data showing that, of course, the DCIS is increasing in an enormous way, 800 times more than in the past, but in the same time, the invasive cancer, the later stage of the cancer is decreasing, arguing that we detect more DCIS to detect less large stage breast cancer, with the benefit of detecting the DCIS. So again, a sort of course, open question, not easy to resolve. And at the end of the story, DCIS is really a different disease that we may differentiate with the genetic profile, the epigenetics, or we may identify some precursors able at a certain point to tell us what to do, or the DCIS are more or less the same, and the only thing that would change is just the natural history, the time of the relapse. Well, we have the only thing that we know for sure regarding DCIS is that radiation therapy can work in DCIS. This is the result of the 3 major trial. I don't want to overlap the next speaker, but for sure the radiation therapy is able to decrease the risk of our invasive, the most dangerous local relapses, but fortunately not impacting the mortality. The mortality seems to be the same. But if we look at the most recent population of women, much younger than in the study of the trials, we are 100% sure that the invasive local relapse may not impact the prognosis, or anyway an invasive local relapse in a young woman may impact the quality of life. Invasive local relapse minimum that you may give to the patient is 5, now 10 years tamoxifen. So we need to think about this possible effect. Of course, with the genetics, the oncotype DS, DCIS, we thought at a certain point to have resolved this question. We know when the DCIS has to be treated with the radiation. But unfortunately, this is a limitation. Is a limitation because the validation was done just in a selected group of patients. The patient entered the trial, Eastern Cooperative Oncology Group trial, in which the cancers were less than 1 centimeter if grade 3, or less than 2.5 centimeter in low grade. But anyway, all these cancers, all the excision had more than 3 millimeter free margin. So population a little different than the population that we may see in our common practice. But if you look at the more sophisticated results into the trials, you can see that unfortunately there are many variants, not only the radiation therapy able to impact the risk of the relapse in basis of DCIS, the age, the method of detection, clinical versus mammography, of course, type, well differentiated, grade, architecture, margins, and of course treatment, radiation, tamoxifen. So it's not only the radiation therapy, it's something a little more complex that we need to take into consideration in evaluating the risk for our patients. And what we learn is that we are doing a little better. In the past, we had more local relapses than now, probably because we learn more how to deal with the DCIS. This is our experience, memorial experience, in which we compare two groups. First, between 1978 to 1998, second 1999 2010, and the local relapses were low. Why? Because probably we were able to better select the patients. We were able to better understand the margins, check the margins, do re-excision, probably without any codification, but more as a gut feeling of the surgeon of the radiation therapy, when to treat with radiation, when to treat with tamoxifen. But at the end, we are doing a little better regarding the risk of local recurrences. Well, everyone knows about the recent recommendation for invasive cancer regarding the margins at Inc. And the same commissions is working for the DCIS too. So sooner or later we would have the same recommendation for DCIS. But it's true if you do your radiation therapy, again, memorial data, but if you don't do radiation therapy, the margins are very important. More than 10 millimeters, less risk of residual disease, and of course, less risk of local recurrences if you don't do your radiation therapy. But not only is important the margin, but also the quantity of DCIS that you have along the margin. And this is another memorial study in which we quantify the number of involved ducts along the close of positive margins, and more DCIS you have, and more risk of local recurrences if you don't do the radiation therapy. If you do the radiation therapy, this difference is of course, less. Age, very important. The age at 30, 40, and we are seeing more and more these patients, the risk is incredibly high. And some surgeons around the world are so concerned that when a young patient has a DCIS, they propose the mastectomy. There is a strong tendency now, and bilateral mastectomy. But if you look at the risk of the invasive local recurrences, you can see that at the beginning they are very similar. What does it mean? That the local recurrences are more or less the same in all the group, but it's the second cancers that are much higher in the young group of the women. So it's more the second cancer, the risk of the failure. Well, it's difficult for the surgeons, unfortunately, to deal with the genomics, with the genetics, and what we do at Memorial, well, we elaborate a sort of algorithm, nanogram, that is online, easy to use, taking in consideration all the factors, margins, age, necrosis, with a very good prediction of the risk. Is online, everyone can do with the patient sit in front, and this is a case scenario, 35 years old, 2 centimeter cluster of microcalcifications, and you know, if you fill your form online, you would have your risk that is, I would say, valid, that is very, very real. Other institutions were able to, of course, validate our nanogram, practical and effective. So I would like to finish that for sure we know that DCIS is probably a different type of diseases of the cells of the male ducts, but unfortunately we are not able now to, based on the genomics, predict the invasive versus the tendency of the invasion. And of course, we wish to have in the near future something a little better than the variants that I show you in better predicting the outcome of our younger and younger patients. Thank you.